Okay, this is our respiratory disorder lecture. This is just a nice visual for you. What we're going to be going over today is obstructive disorders of the respiratory tract, and we're going to be focusing on asthma, emphysema, and chronic bronchitis, with emphysema and chronic bronchitis making up COPD. Just a little visual here that I want you to take a look at as a reminder of how our body becomes oxygenated and how we get rid of our CO2, and how maybe an alveoli might look if it has exudate and fluid. The oxygen cannot pass through the capillary membranes very well to oxygenate our body. And the same with our CO2, it cannot get exhaled properly because of the fluid, not allowing it to pass through the capillary membrane. So first, let's talk about asthma. So asthma is a chronic inflammatory disease. It's triggered by allergens, exercise, or infection. It's considered an intermittent airway obstruction disorder where the bronchial tubules are narrowed and mucus production is formed. The mucus production is to try to get the allergen out of your lungs, and the narrowed tubular is part of the inflammatory process. We have a bronchial hyperresponsiveness, which is a sensitivity to the allergen, and then we have the inflammation part that obstructs the lumens. So this is an inflammatory response problem to the allergen, exercise, or infection. So what happens is our T helper cells 1 and 2 produce IgE, so immunoglobulin E, and then we have mast cells that help release histamine and leukotrienes. Remember, this is the inflammatory process, so histamines and leukotrienes increase inflammation. Our histamines from our mast cells produce bronchospasms and inflammation. Our leukotrienes produce bronchoconstriction and hyperactivity along with edema. And then our cytokines, also part of the inflammatory process, kind of maintain this damaging effect. So keep it in place, because this really is all to help our body fight this allergen or infection. But sometimes it goes a little bit too far because we do have to breathe. And so the mucus and the constriction can become too much. We also have a cholinergic effect that occurs, which is bronchoconstriction and increased mucus production. So I have bolded these because some of these you're going names, the mast cells, histamines, and leukotrienes, and the cholinergics we use to help reverse this inflammatory process a little bit so at least your patient can breathe. So let me just make this a little bit larger. This is our normal bronchial tubule. So our tubule narrows with the inflammation, and which, as you can see, the diameter here would be much difficult to breathe. Plus in here we have our mucus secretions. Over time, that inflammatory process can cause this wall to become thickened with repeat exposures, making the asthma attacks even worse each time. Okay, so here's some medications, and these medications can actually be used for asthma, chronic bronchitis, and emphysema. The two primary ones that we use are the beta-2 agonists and the anticholinergics. So we have some differences here. We have albuterol, which is an inhaler, which is short-acting. We also have salmeterol, which is long-acting. Now, whenever we're giving our bronchodilators, if a steroid anti-inflammatory is ordered as well to be inhaled, we always want to do our bronchodilators first, because we want to dilate the bronchial airways, open them up, so that when the patient inhales the steroids can actually get into the lungs. Okay. With our long-acting bronchodilators, very, very common that steroids are used also. So albuterol is short-acting beta-2 agonist, and our salmeterol is long-acting beta-2 agonist. If a patient can't tolerate the beta-2 agonist, which is the sympathetic nervous system agonist, then the doctor can also prescribe anticholinergics. For these, it's ipratropium and tiotropium, and the ipratropium is short-acting, and the tiotropium is long-acting. So what this means by short and long-acting is these are the rescue inhalers. So the albuterol, the short-actings, are the rescue inhalers, ipratropium and albuterol. Then we have our xanthine or methylxanthine, which is aminophylline or theophylline, and then our phosphodiesterase inhibitors, which is roflumilast. In our steroids, or anti-inflammatory, our steroids are widely used. So you'll see fluticasone, beclomethasone, and these are both inhaled. And remember, we use them after the B2s. And then we can also use prednisone PO for serious exacerbated effects. We have mast cell stabilizers and leukotriene modifiers. So if you remember in our previous slide, we have mast cells and we have leukotrienes. So if we have a mast cell stabilizer, that is cromolyn, so that will stop the mast cells from causing inflammation or inhibit it. And so we can use that as a treatment. Same with the leukotriene modifiers. Montelukast is very, very common. Both of these are common, and they do the same things. These both inhibit the inflammatory response. They are starting to use an immune modulator as well for asthma, which is omalizumab. So MAB, I've mentioned these before, are immune modulators. Typically they're IVs. This would be someone that is not doing very well with the normal treatment for anti-inflammatories. Okay, so what does this all mean? It means bronchoconstriction, bronchospasms, narrowing of the airway, and increased mucus production. If this is repeated over and over again, we can get permanent inflammatory changes and bronchial remodeling. The mucus production itself can obstruct the airway. As you can see here, we have a mucus plug, so a large area of mucus, and then with the bronchospasm, it can completely obstruct the airway. So we need to get those bronchodilators and our anti-inflammatories in place to help this from happening.